Thanks for the invitation to be here today. So our team is always thrilled to be able to share this work that we're so passionate about and involves a huge amount of people. And I would like to, so we're going to be talking about cervical cancer screening experiences in northern BC that we've been working on for the past 5 years or so. And I do want to start by acknowledging the fact that the work that we do, most of it is done on stolen land, on unceded territories. Some of it is treaty territory. And I myself am presenting today from Lheidli territory, where I live as an uninvited guest. And the territory is also includes chartered Métis communities, who we work closely with as well. And in way of introduction, I am a, you heard about my training. I'm conventionally trained in obstetrics and gynecology and in public health as well. And I'm a 6th generation settler on the territory of the Alexander and Paul First Nation, which falls under Treaty 6 territory. But I myself was not born on the lands that we call Canada. And so I come to you in discussion today, very much from a settler worldview and conventional Western colonial training. And with that, I want to introduce my colleague, Katina. So Katina, could you introduce yourself?
Certainly. Thank you so much, Sheona. And thank you, Stephanie, for inviting us here today and having this opportunity to present to such an amazing group of people. I'm so excited to be a part of this project. It's truly been one of the best experiences in my working career. And I'm just really excited to be here today to share many of the successes we've had within this project. So Tanje Kia Wow, Shanika Shan Katina Pollard, Ni Papa Zakal Shanika Show, Mi Mama Gladys Shanika Show. So hello everyone, my name is Katina Pollard. My pronouns are she and her. I'm a proud community member of the Thompson Okanagan Métis Association and Lower Similkameen Indian Band. My family names are Zakal and Gladys, and my role at Métis Nation, British Columbia is the HPV project assistant. I want to respectfully acknowledge that I'm calling in today from the unceded ancestral and traditional territories of the Treaty Nations, as well, which is home to the Kelly Lake Métis Settlement Society in Tumbler Ridge. So maybe I'll pass it back over to you, Sheona. Thank you.
Thanks, Katina. And so we would encourage you to just put in the chat the lands that you're on, and anything else any other way you'd like to introduce yourself. And please do, as questions come up, please ask them. I don't know if I'll see the chat popping up, but I'll get Katina and Stephanie just to bring things to my attention so nobody feels ignored. And we have designed it so we do have hopefully lots of time for questions at the end, because that's really where the richness of things is, in that learning together. I know many of you, I know you, or others I follow you on Twitter, but thank you so much everyone for joining today. And we want to start by acknowledging that I can get my slides to move, that we are not technologically up to date. Okay, we'll just see how it goes here. Awesome. Okay. So although it's Katina and myself chatting with you today, there is a massive crew that makes this work happen. So across the different kind of organizations and communities that we work with. And so we're always privileged to share this in, academic and clinical settings, but please know that there's people at the community level, at the clinical level, several different organizations at health region levels that are committed and involved in this work, and we're thrilled to work with them. To give you an idea of across the province, all of the projects that are focused on self-screening, so offering cervical cancer screening with self-collected swabs. These are like the original projects, and now there's some larger ones being rolled out as well, which is great. And so the ones we're going to be talking about are those in the north, so partnered with the First Nations Health Authority, with Métis Nation BC that Katina is going to be sharing about, with Carrie-Sakani Family Services. But the other two projects, the Fraser Cervix Check is ongoing. And then there was a small project in Westbank First Nation as well that Anjali Malhotra headed up. And so that's just kind of the geography of things. We always, when we do this type of presentation, everyone wants to know, like, why is it only available in these northern projects? Why can't everybody have it? And we chose the north for several reasons. But a critical piece was addressing where there was the most disparity in access to screening. And so across Canada, we do have vast geographies that can make access to screening challenging. There's incredible health system capacity issues that have been highlighted, obviously, by COVID, and just human resources. So distance to traveling to a clinic. There's personal reasons as well. And issues around not just intergenerational trauma, but personal histories of trauma as well that can impact whether or not you're going to access care that involves a somewhat uniquely invasive pelvic examination. And so that was part of the motivation behind specifically focusing on some northern communities, and also very specifically focusing on Indigenous women. And I'm sure everyone, this being a gynecologic cancer crowd, is aware in the disparities that we see among cervical cancer, invasive cervical cancer rates among First Nations women. We know even less about Métis women in BC. And those with a cervix. But one of the key factors that has been described is the lack of culturally safe options for cervical cancer screening as a significant factor in why we're seeing these really unacceptable rates of invasive cervical cancer in something that we have not only vaccines for, but really effective options for screening. And one of the places, obviously, that we start this work is that we have this idea. So we have a technology, a tool, an option that allows a tool to be put in the hands of women and those with a cervix that they have control over, so that they can self-screen and not have that initial pelvic exam. But what has been key to these projects in the north is that while we have this tool and obviously like clinical expertise on how it can be used and what kind of follow-up needs to happen, the actual way that communities are engaged and how participants are offered this tool has been drastically different across these communities. So whether that means a fully kind of online approach where you just go to the website, create your account, and you can get a swab mailed to you, whether that's kind of a combination where you can pick up a swab at a health center or a friendship center, or whether it's fully integrated into kind of a primary care clinic where the screening is offered to you there and you collect it there. All of these have been different approaches that wasn't part of the research team or the clinical team that made those decisions at all. It was all the decision of each community and what they thought would be most effective and what was going to work for their setting. And obviously these are things that have changed over time as we've learned and seen what has been effective and what hasn't been effective. And I'll hand it over to Katina to share about what that process has looked like specifically for our Métis Nation communities that we're engaged with.
Thanks, Sheona. So to take you guys on a bit of a timeline of the project, these conversations really started back with Métis Nation BC's Senior Director, Tanya Dabrin, Sheona, and a team of folks who really have a passion for Indigenous health and specifically around Indigenous, rural and remote Indigenous cervical cancer screening. So as these conversations evolved, it was just really natural for the work to evolve as well. So in 2019, I was hired into the position of HPV project assistant and immediately began doing community engagement within our Métis chartered communities. So I was really fortunate where I held another position at Métis Nation. So had a lot of involvement pretty much on a day-to-day basis with our communities. So I really knew the communities and leadership fairly well. That being said, I just wanted to pause and really talk about the importance of building those important relationships within our communities. So prior to launching the project, we focused on each individual community and really wanting to understand the challenges Métis people face when accessing healthcare services in the North. So what we learned was that it's very common for a common experience for Canadians to not know much about who the Métis are or the historical injustices done to Métis people. So it was really vital that we understood the unique needs of Métis people prior to moving this work forward in a good way. So by doing so, we heard really loud and clear that it was essential for the voices of Métis Nation citizens to be heard throughout this project, as well making sure the processes were culturally safe, as Sheona mentioned earlier, and traditions were embedded into the project. So some of the other key priorities we engaged with communities included training the communities and just having that awareness of the project, and as well identifying the communities in most need of this essential health service. And through this engagement, we were able to launch in 3 of our Northwest chartered communities, so in Smithers, Terrace, and Prince Rupert by early 2021. And then today, the recruitment process is still underway in those Northwest chartered communities. Next slide, please. Great. So I just wanted to touch briefly on this slide around community, the community engagement component. So COVID-19 has certainly impacted how we engage with community. Historically, our engagements and gatherings have been primarily done in person. So we've really had to listen to our communities on how they wanted this project to roll out during this time. As you can see, we hosted a few online workshops, and one of them being a beading workshop, which was really well received within our communities. Brought multiple folks together to learn and ask questions about the self-collection project. We also provide a monthly newsletter, which highlights changes and updates to the project. Next slide, please. Okay, so this slide is a bit of an overview of the participation in the Northwest so far. So this to me is an important takeaway, just because this really shows the screening, the lack of screening within some of our participants. So as you can see, 4 out of 25 participants had no screening history, and 17 out of 25 had not been screened in 5 years or more. So this really shows we're reaching those folks for whatever reason have not been accessing a cervical cancer screening prior to this program starting. Next slide, please. So this slide, to me, is one of the most important parts of this project besides the community engagement component. So this slide is our survey results identifying gaps and key learnings that will really improve this work moving forward. So we just really appreciate receiving and reviewing the feedback from our participants. Although it's important to identify those learnings, I also think it's important to share the successes of the project. So I really just wanted to end with sharing something that has recently been told by a participant, that this project not only puts trust back into the system, but I just appreciate the local support and thoughtful follow-up care provided by Métis Nation BC. So that ends my portion. I just wanted to thank everyone for your undivided attention, and I'll pass it back over to Sheona to talk more about some other amazing projects happening in the North. Thank you.
Thank you so much, Katina. And now I'd like to chat about the projects that we have in our First Nations that are partnered with the First Nations Health Authority. So I noticed in people's introductions that there's folks joining from like Botswana and Morocco, which is fantastic. And so just just so everybody knows, the context in British Columbia is that we do have a First Nations Health Authority, and that was created several years ago, as well as each different regional health authorities. And so the First Nations Health Authority kind of works in parallel, but individual communities can actually choose to be connected with First Nations Health Authority to provide them with healthcare, or they can connect and provide that within their own communities and different internal organizations. So these three communities are would be considered fairly remote. So these distances are absolutely huge. So Fort Nelson First Nation is fairly close to the border with the Yukon. And this, while the other arms of the project are funded through CIHR, the Canadian Institute for Health Research, the FNHA arm is actually funded through just a private family foundation that was made aware of the project of the other work that we're doing through the UBC Foundation. And so again, as far as the timeline for this, these discussions happened over several years, and it wasn't, and it took a lot of discussions around what this would look like. So this was foundation funding, so it didn't have to be a research project per se, and that was one of the actually really tricky conversations. And we talked about whether we were doing project implementation versus a research study, and what the nuances of those were. And also partly because of where FNHA is currently at with their process of developing an ethics, ethics process as well. And where communities were at and what they wanted. This took a really long time, and these were really challenging discussions and quite nuanced, and a lot of people hours and time was spent in figuring out what the optimal approach was, and ultimately it was through a formal ethics process that we proceeded, but that wasn't necessarily at the request of the communities. And we started with these three First Nations communities, and it was funny. We were in a meeting the other day with Sarah Pike, who's one of the senior managers for the STBBI approaches with FNHA, who's been involved for many years with this project. And she's like, "Why did we pick those communities again? Like, those are the hardest ones." And so it was funny reflecting back on that, because that's actually part of what this project was about, picking like who doesn't have access to this, and actually like throwing ourselves in and saying, hey, we're up for it. Like, let's see how this pans out, because everybody deserves to have access to screening. And so we've done a lot of wellness days. We try to do it in conjunction with the Mammovan, the mammography program with BC Cancer, to have wellness days. Obviously, again, COVID has devastated these communities, and we've had a few last minute cancellations of these trips as well, due to COVID, and that has been a big challenge. And so we are always optimistic, and do have more in-person days coming up in the spring, which we're quite excited about. And again, looking at the number of participants, and obviously we're offering this in an ongoing manner at health centers, but there does tend to be a lot more engagement at those, like the actual wellness days, where people are just come and participate and get screened. And again, we are seeing a really significant number of folks who haven't been screened in 5 or more years. And so in BC, we screen with pap smears every 3 years. And so it's not just that folks are due for their pap, they're significantly under-screened. And so obviously most at risk for developing cervical dysplasia and cervical cancer. And the next project is with Carrie-Sakani Family Services. So this is an Indigenous organization who provides healthcare for these 11 Carrier and Sakani communities in what we call the Northern Central Interior, as you can see here on the map. So these yellow communities. The approach that we took with Carrie-Sakani, so they're one of the most kind of like established projects as far as how long they've been screening. And we had this incredible engagement at the community level, and specifically with the care providers. So the physicians who provide care in these communities. We've been able to collaborate on a few publications as well with Carrie-Sakani that we're really proud of, and really glad to have moved forward in a good way. And I can tell you that took a lot of back and forth with different journals about how we described our methods. And one of the specific things that the communities had asked for was to actually, like, we want to tell a good news story. Like, we want to have a strengths-based publication. And for anyone in research, strengths-based publications aren't not necessarily what everyone wants to hear about. Like, we want to hear about the pathology and what problem we're fixing, right? And so that was a really interesting dance that we had between what is, our settler academic research structure and what Carrie-Sakani was actually asking us for. And there was a huge amount of learning for everyone throughout this process. And one of the mottos that, because it's very humbling, and I think one of the messages or kind of sayings that I keep with me is like, when we know better, we do better. And we did a lot of things wrong, and we learned a lot, and that is all informing how we move forward. And Carrie-Sakani has this amazing communications team. And so we've really been able to do a lot of work together with them on kind of how we get messages out through newsletters, through direct community engagement. And we've had some awesome support. There's a picture here of Bianca, who's been works at the main office in Prince George, but is always up for ensuring that we have like appropriate content on our promotional materials as well, which is really fantastic. And so it does mean a lot of community visits, obviously pre-COVID, and now obviously we are kind of continuing with that as well. But because of the Carrie-Sakani model and how they have care providers that are like connected with each individual community, we've had like a significant bump in participants during COVID. And I think that's one of the really neat things about this approach as an intervention is that it's one of those pandemic-proof interventions. So even if you can't have an in-person clinical appointment, even if there's no one physically going out to communities, this is still a swab that women can choose to take and collect, and really have control over when and how they're screening, when there were so many things that was not in their control during the pandemic. And again, so it's been going on for a bit longer, so much higher number of participants. And the two key things with this, one is that in any of the projects I've ever been involved in, whether it's in, Uganda or remote communities in the north, everybody's always excited about it. Yes, like, absolutely, I want to participate. And that's fantastic. And the most challenging part is not in like recruitment and engagement, but it tends to be in follow-up and making sure, like, okay, that's great if you're negative, but what if you're positive? Like, that means you're, absolutely need follow-up, and that will definitely require that pelvic exam. And so there has been like really excellent follow-up for those who have been positive. And we're also, that's obviously something that we're going to be following closely with our FNHA communities and the Métis Nation communities as well, because these are involving a very disparate and spread out geographies. So making sure that folks have the ability to travel for that follow-up. And similarly as well, a huge amount of participants so almost half of our participants haven't been screened within the past 5 years. So it's encouraging in that we're really able to offer this option to folks who wouldn't otherwise have access to it. And so that's kind of the update on where our projects are at. And I did want to, I want to share a bit of the work that one of my graduate students did. So Marina Giovannini, I think she's joining us today. That's awesome. And so Marina's work was quite focused on patient voices, so patient-oriented research. But one of the cool kind of directed readings she did in preparation for this was around the actual determinants of Indigenous women's health in the North. And a specific part of that was working on a lot of self-reflection and just learning around what it means to be a white settler doing Indigenous women's health research. And when we, for those who aren't familiar with the Canadian setting as well, there is a dark and ongoing legacy of colonialism that has left a huge impact on Indigenous peoples in Canada, and continues to be exacerbated by a lot of our systems, and specifically around women's health. And because we're talking about gynecologic cancers, this has huge impacts specifically on women and how they've been able to access reproductive care, and the lack of choices that they've had in the past over their reproductive care and continue to have. And so I hope that you feel unsettled in this discussion. I do invite you into some discomfort, because I know I'm uncomfortable talking about it. But it is so critical if we want to actually engage genuinely and ethically, and move in any way towards reconciliation, is that we actually have to acknowledge that we work in a structure that is inherently colonial, and because of that, it is by design going to be racist, and this has massive implications on how we do health research, and I would argue even has more impact on women's health research as well. And so this is a quote that Marina's used a lot about researchers being mosquitoes. They suck your blood and leave. And that's specifically a part of our the legacy of Indian hospitals, the ongoing impact of residential schools, where research was used in horrendous ways. And that is what we work in. That is the system that we continue to work in. And so Marina put together, these were, so this was kind of the knowledge product that she put together for the end of this directed readings course, as far as, tips for just where to start as a white settler engaging in Indigenous health research. And obviously a critical part of that is acknowledging our own biases, acknowledging our own racism, really taking time to understand the context that we're working on and the history, and understanding that it's not solely something that happened in the past, but this has ongoing implications for how we provide care and how we do research. I loved her point about giving credit to the people you're researching, because I think that is a really challenging one because our academic system is so individually focused. And so our graduate students, we want them to get grants, we want them to publish papers so that they can progress in their career. But the truth is that it isn't our data. This is the women's stories that we are sharing. And what does that mean when we go to try to, use this information to try to improve health systems? So as we've gone through all of these projects in the North, we're so proud of the work we've done. We've had a lot of successes, but we're also really uncomfortable about the work. And we have a lot of areas that where we have failed and we need to do better. When I think about kind of how we define a successful academic or a successful research project, a lot of things we think about are, how many grants do we have? What publications are we first author on? And part of it is that recognition that we need to have. So are we known as a researcher, provincially? Are we known nationally or globally? And that's a big part of how you get, proceed through tenure in academic settings, certainly at UBC. It's very specific about how things progress. But when we look at our setting in Canada, similar to our acknowledging that the impacts of our health system on Indigenous health are specifically due to federal policies, I think we have to acknowledge that as well within our research systems. And so these projects are largely funded by CIHR, which is a settler institution. So these federal sources of funding for specific calls with specific deliverables that aren't things that communities necessarily get to choose. And a big focus on within academia on individualism, right? So like, what am I doing as a researcher? And instead of having, the Indigenous Health Group at the Royal College publish this work, we get much more benefit from within our system by those individual publications, rather than really complex big teams that have done that actually require a lot more work and do more sustainable and long-term work than some work that's done with smaller teams. And so these are really uncomfortable realities, and all of our approaches in general tend to be at the individual level, that the self-acknowledgement, the self-critique, the individual connecting with in the ways that we try to connect. But I think where I would kind of bring this talk to a close and hopefully be able to have some discussion is just to remember that we won't be able to close these gaps that we see in outcomes without first acknowledging that our research system is inherently colonial, and we work in a completely different paradigm than what is kind of how health is seen in Indigenous communities. And as I talk about this and closing these gaps, I speak to you as a settler. And these gaps, you've heard this before, I'm sure, we talk about like these Indigenous issues. And I want to be clear that these are not Indigenous issues, these are settler issues. And when we think about those who can affect change in our healthcare system, and definitely in the healthcare research, different levels of health research, a huge portion of that is dealing with our settler issues. And so I would really invite you to think about what that might look like and what kind of systems change we can contribute to make that happen. And so I'll bring things to a close there. And I would again just want to thank the Katina specifically, but the huge team that we have, many of whom are joining on the call today as well. And just really wanted to open it up to any questions that people had or thoughts for discussion.